Um, Thanks everyone for joining us for our community practice on qualitative health research methods. I'd like to begin by acknowledging the traditional owners and paying respect to the traditional owners of the lands wherever everyone's joining us from. I'm on Gadigal land at the University of Sydney. We have a session today about ethnography. I myself am an ethnographer, so I'm super excited about this. And I'd also just like to acknowledge Catherine, who's my co-facilitator today. So we have two ethnographers with us, Dr. Suyin Ho, and we've also got Sam, who's down the bottom here. You can wave hello. And we're going to start off with Su Yin, who is a senior lecturer at UTS, and she has a background in psychology, education, sociology, science, and technology studies. She's currently an investigator on two NHMRC projects examining experiences of infection prevention and control during the pandemic and community preparedness for future pandemics. So I invited Su Yin because I think it was during COVID, I watched one of her presentations about video reflexive ethnography, and it has stuck with me for years because it was so exciting. So I'm really happy to be sharing this or allowing her to kind of share this with everybody else today because it's really great research.
Thanks so much, Victoria. I'm thrilled to be here. Thank you so much for inviting me. Would you like me to start sharing now? Yep, okay. So it worked well just now. Let's hope it works fine. Oh, no, not presenter view, sorry. Classic. Okay, in a minute. Okay, here we go. So we should be looking at the slide, video reflexive ethnography with my name on it. Yeah. Okay, perfect. All right, hi everyone. Thank you so much again for coming and listening to this. I present today to you some work that I've been doing over the last, decade or so, primarily in collaborations. And none of this is me alone, right? It's collaboration with Rick Edema, who's my supervisor in my PhD, and then, mentor and supervisor beyond that. Lynn Gilbert, who was also, he's an amazing leader in microbiology and infection prevention and control. And she was kind of a strong champion of this methodology in practice. And Dr. Mary Wire, who was my PhD student and now is a close friend and also an incredible researcher. Okay, so all this work is in collaboration with them. And I'm joining you today from the unceded lands of the Gadigal people of the Eora Nation. And I too pay my respects to their elders, past and present. Okay, so what I'm going to do today is to give you a bit of a kind of intro. I spoke to Catherine and Victoria, and I understand that this community practice is sort of broadly interested in methodologies, qualitative type methodologies. And so I'm going to give you a brief introduction, but I'm always available to answer questions because I know this, because it's a little bit unusual if you've not come across this kind of research before, and I'm always keen to talk about it. So if you want to reach out later with an email or anything, feel free to, because I will welcome that gladly. Okay, so what is video reflexive ethnography? It's a mouthful. Most people who aren't familiar with it will call it something else. That video reflex stuff, the video reflexology, that video ethnography with reflective stuff. The point is that it's actually a methodology. It has a lot in common with other methodologies that you might already know. So we use video, and that's very closely related to video ethnography. It's a participatory method, so it has and often has an interventionist aim. So it has a lot of links with participatory action research, all the co-design, production research that's being done now. And it's based on reflexivity as a key principle. And by this, we don't only mean research reflexivity, which again, most qualitative researchers will be familiar with, but more the idea of reflexivity as a process of sense-making amongst a diverse group. So, between participants and the researcher. So, if you're familiar with ethnography, one of the key methods is participant observation, right? VRE, we do something that's a little bit more like participant interference. So there is observation. There's often a lot of, field work, spending time, doing this deep hanging out. But what we're also trying to do is facilitate participants to, in a sense, observe themselves. Okay, and in doing so, we interfere in practice. We do this because we believe that research, that wants to gain traction with the complexity of healthcare needs to do so by wading into the complexity, not standing at a distance. Okay, so first I'm going to give you an example. Now, I wasn't confident that video was going to work over Teams because we haven't had much luck before. But so what I'm going to do is I'm going to I got some screenshots of a clip that I often show. Okay, and I'll kind of just sweep you through it. Okay, so I'm sorry it's not as nice a flow as a video, but on Teams I find that there isn't usually that kind of nice flow anyway. It's very jumpy. Okay, so this is just to prepare. It's a clip about a group of nurses and a wardsman moving a patient out of an open bed space in an ICU into a single room. And this was from a project prior to the pandemic. Okay. Now, so let's see. Okay, so this is, you can see they're all masked and gowned because the patient has just been identified to have rhinovirus. And of course, because this is an ICU, rhinovirus is a serious threat to, the other patients around them and to themselves. So they've got the gowns, they've got the masks, okay? And they're moving the patient with the bed, all the equipment, poles, IV things, machines, okay? And then as the clip plays, you'll see that they actually have a lot of difficulty moving this patient and their bed and all the equipment through the ward. And so, what the participants watched was this process of them, slowly moving things out of the way, pushing computers, chairs, bins, curtains, poles. And, I think now that we're quite a conscious audience, or sorry, a conscious community about infection control, and we understand the risks of all this touching, right? If you have your PPE on because you're touching the patient's bed and all the equipment, the chances you're contaminated with some of the pathogens that the patient has, and if you're touching other surfaces, those are opportunities for cross-contamination. And in the hospital context, we have the 5 moments. Most of you are probably familiar with that. And the idea is you wash your hands between touching the patient or the patient's equipment and touching the surroundings. But in this scenario, that's not quite relevant, or it's not quite realistic. So and in this clip as well, we kind of shift to this room, which is where I'm talking to, I think in this one, it was predominantly nurses, okay, a room of staff members having what we call a reflexive discussion. So they're watching this clip, and this is only, what I'm going to show you is only like a couple of minutes out of an hour-long session, out of many sessions and many different clips. But in this one, they're looking at it and they're going, look, it's so crowded, right? And they clearly see for themselves the infection control risks of the cross-contamination. And that's me in the middle, much younger. And some of the people in the clip were also in that room, okay? So that's me asking them, sorry, what do you think you can do to make this easier for you? Because they've identified it's an issue. Well, then one of the nurses, I think it was here, saying, well, if you prepare it before, like you clear out the space before you enter the room, okay? And then another person says, oh, but there was actually, when they were moving, there was also an X-ray happening. So they're starting to expand the context, and they can see it in the clip still. So there's a mobile X-ray machine a little bit further down the corridor on top of the normal crowdedness. So the X-ray is at bed 8. If you look at the answer, it kind of wrecks the movement. This is what they're telling each other, right? And then the context gets expanded even further because somebody says, that was the day when we actually had to move at least 4 patients. We had musical beds because we found out this gentleman had a rhinovirus, another lady had influenza A. So it was really busy that time. That's why probably, as that nurse had said, the whole unit is like chaos. Okay. And then somebody says, well, maybe, and this is actually a student nurse, out of interest in red here. She says, maybe we need to have somebody whose sole responsibility is to walk ahead of the bed so they can move all the equipment out of the way. They don't have gowns on or anything. And I say, well, is that something you can do, right? This is just me facilitating. And they say, yeah, we can prepare, yeah. The nurses could allocate somebody to do that. And this is a number of people all talking to each other now, not just one. And then they make the observation that usually, everyone crowds around the patient thinking, patient first. But you forget about preparing the environment, really. So that's, they called it a mistake, but it was more like a realization, right? And so a few months later, I visited the ward again and found that they were kind of continuing to do this practice, allocating somebody to clear the way ahead before moving a patient. It makes it a lot easier, reduces cross-contamination. Okay, so like I said before, this is really a small, couple of minutes out of, one session, and it's a lot more involved than that. But I think it gives a nice picture of what it looks like. And again, sorry, that's not a video, but yeah, I hope it gives you an impression of what it looks like. All right, what's next? Okay, so just some words. Video reflexive ethnography. In essence, it's working with participants to video practices of interest. These are usually routine, everyday practices, and then making sense of the footage collaboratively in reflexive sessions, like we saw in that tea room. But there are so many other different kinds of settings. Like here we are in a doctor's room, in another tea room, an education room, that kind of thing. So this is what it looks like. What we try to do is to invite practitioners to see their work as complex, right? And we use the video not necessarily as proof of what happens, but as a stimulus for reflexive discussion with and between participants. I often get the question, well, aren't they going to behave differently because you're videoing them? It's quite obvious that you're videoing them. And I go, yes and no, because obviously they'll be conscious. Sometimes over time they forget, but even if they are conscious, what they're doing is often so kind of complex and interconnected that they can't necessarily change it that much. And the other thing is, if you show footage of a normal, ordinary practice back to people who are familiar with that practice and the context, they will recognize when it's unusual as well. So once, for example, I videoed a very busy workstation, and I took the sound off because I didn't want to accidentally record any confidential information. And when I showed it back, they just talked about how noisy it was, even though the clip had no sound in it. So that's kind of the point of the video, to stimulate the reflexive discussion. And in a way, for those of us who work in the kind of knowledge translation area, it's a way of addressing this gap between sort of the generation of evidence and then the application into practice again. It kind of narrows it down, puts that all kind of into the doing of the method, okay, in the context itself. So what happens in these reflexive sessions? So people often see their work from a different perspective. This is this notion of giving them a distance from their normal environment, a third-party perspective. We encourage collective sense making. So this idea of reflexivity again, they identify, because people, when they look at their own work, first, they take a couple of minutes to kind of adjust to the idea of seeing them from their back or whatever. And then they start, criticizing themselves often. So they'll identify issues, but if facilitated, appropriately, they'll also identify strengths, yeah, in their work. How is it that they do such complex work so well, Then often you get contradictions, confusion, contentions raised in discussion. The policy says this, but that policy says something different, or this is how we were taught at uni, but that doesn't work, and that's actually a health risk, that kind of thing. It all comes to the fore. And it's a really helpful way as well of surfacing and examining assumptions, norms, ways of thinking, ways of working, the kinds of things that kind of make up culture, and linking it back again to the idea of ethnography. That's sort of the kind of things that we try to elicit as well. And so sometimes, often, locally meaningful improvements are shared or developed. That's not always the point of the project. Not all the projects are, oriented towards improvement, but that is something that often does happen too. Okay, so again, why use video? Oh, I think I've said some of this already, but the idea is it actually works really well because, healthcare staff are just kind of they're over it in a lot of ways, not just because of the pandemic. Like prior to the pandemic, they were over it too, there is so much, they're often told you're just not doing it well enough. All these indicators are suggesting that this is not good enough, you need to improve. That's the kind of the shame and the shame inherent in this discourse about improvement. And what video does and what this method does is it really gives them something that's engaging and interesting, right? I mean, we have to do it in such a way that they feel safe participating, but it's also interesting, it's engaging, it makes the familiar strange, and that's something that Dawn Manet talked about as well. And video kind of allows you to capture more of the context than you would from, say, written observations or photos even. You're taking in space, movement, people, things, sound, interactions, and also can be rewatched. It's like keeping a representation of practice warm in the moment rather than kind of freezing it for dissection and analysis, keeping it warm in the moment and inviting people to see it, different people from different contexts, and it allows for multiple interpretations. The hologrammatic effect here is something that Ricky Dima came up with, and he just pointed out that when, like I said before, you're looking at footage when you know the context, you often see more than what's just shown in the clip. So I think I might have a minute to show you another example. So this is a study led by Mary Wire, who I mentioned before. She was my PhD student. Now she's a biocontainment nurse educator and researcher at Sydney Uni. And this is a story this is a project came out of a PhD research. And when I looked at infection control with staff, she looked at it with patients. Okay. And out of that, we realized that, well, patients, first of all, were concerned about infection control, but really not sure what to do about it. And they learned mainly by watching staff. Okay. And they came up with their own strategies and their own, logic and their own ideas about infection control. And then staff would often complain that patients, are doing the wrong thing. But then when questioned, we all realized that staff didn't feel able to speak to patients about this. They often left it to the infection control nurse, and there's often one, if you're lucky, in a big hospital. So it was unrealistic to expect the infection control nurse to do all the talking to patients about infection control. So we decided to create a project around that, looking at how communication happens with patients around infection control. And then what we decided to do was follow a swab. So we were inspired by a project that was conducted by Catherine Carroll and Jess Mesman over in Mayo Clinic in the US. And they looked at kind of the communication between breast surgery, so breast cancer surgery in a theater and the lab. They had this program going where they would take the specimen and immediately bring it to the lab. The lab would look at it and tell the theater staff whether they needed to take out more of the specimen. That's kind of my layperson understanding of this. And they did that, they videoed that, and then they were able to sort of, explore how communication happened between the lab and the theater. So here what we did was we followed the journey of a swab, and this swab was a weekly point prevalence survey taken of all the patients in this ward to see if they had a multi-resistant organism like MRSA or VRE or a few other things, so that they could be isolated or treated depending on what it was. So we followed this swab. We followed from the morning where the nurses would print the stickers, to speak to the patient, explaining what they were doing, take the swab, send the sample to the lab. We followed the sample through the machine, how it landed in the lab, where it went in the lab, how it was prepared for analysis, how the results showed up on the computer, and then how that then got fed back into the systems, back to the infection control department, and then all the way back to when the nurse has to speak to a patient about a positive result. So I said, Mary led this project, and we have hours of footage. And, lots of touch points of communication, not just between clinicians and patients, but also between the lab and the ward, and between the lab and the infection control department. So, for example, and we showed this footage back to each group kind of separately and then together again. And what we found were things like the ward was like, oh, is that what it means when you get this particular kind of result, which was kind of like, was it a preliminary result? Because they were often taking that and isolating patients and then finding out later that preliminary result was wrong or something like that. So there were all these little kind of communication issues that were kind of brought up and discussed and clarified through this process. And then other things that were clarified were also the conversations that happened at this point, with the patients, what nurses were saying to the patient, what patients were understanding from it, and then later again, how to deliver, news about a positive result. So some of the things, just to give you a quick example, because I think we need to move on, are, for example, how to describe what the point of the swab was. And I think this is a nice kind of way of explaining how it all worked. So this is Mary's poster. She presented at a conference. And in the middle is the original interaction between, say, the nurse and the patient. Okay, so they're talking about taking the swab and the point of taking the swab. The second window is the researcher, this is Mary, and the patient. And the Mary's asking the patient, what did you understand from this conversation? And the patient would say all kinds of things like, I didn't understand what she was talking about until she said, bugs that you might bring or catch, right? And it became clear again that patients just really didn't understand. Some patients thought that they were at fault if they got a bug. And lots of things like that, including questions about where the swab should be taken from and things like that, including a whole conversation about where the perineum was. So that was quite interesting. So anyway, we then showed it, as you can see here, to the broader audience at a reflexive session with clinicians. And, the nurses said things like, we need a little script so that we have, some sentences in mind for how to explain what we're doing to patients. Maybe we need some education that can be shown on the TV so that patients are just a little bit more aware. Maybe we need some pictures, like a little guide, and just more general kind of infection control awareness. Okay, so some of the resources that were developed. Ooh, that circle moved, not meant to be there. It's meant to be here. So there's just some written information and some pictures, and a script that was developed, as well as, they found some resources that were already available to hand out to patients. Okay, so that's just an example, and there are lots and lots of examples. Internationally, there are now 78 members of the Video Reflexive Ethnography Association in the world across 9 countries. I mean, unfortunately, it's primarily the global north, so, like Europe and UK and the US. But I think it's spreading. I heard of a study recently in Saudi Arabia, and there was some amazing work being done, I think, in Charles Darwin University here as well. So, yeah, so there are so many things that are looked at with video reflexive ethnography. Lots of stuff around communication. Catherine Carroll's done amazing work around human milk banking. Aileen Collier has done work around palliative care and safety. Some GPs and pharmacists are looking at medication safety and polypharmacy, consultations in the UK. Yeah, there's just a lot going on, and it's a growing field. So I think I have maybe 1 or 2 more minutes. Victoria, what do you think? Is that all right? Or do you want me to wrap up?
Maybe getting close to wrapping up, just so
Yeah,
that we have
okay.
enough time for discussion at the end. Yeah.
No worries. So how do you do a VRE study? Okay, I'm just going to present the kind of the methodological thinking behind this as a researcher. So like I said before, to gain traction with complexity, we rely on being embedded and entangled in practice. Okay, so in terms of making decisions about what to do in this kind of research, we do something called thinking or doing with theory. And there is this great book that kind of goes through that. And if you're interested in this idea of thinking with theory or doing with theory, I would recommend that. Okay, so these are the sort of 4 principles that we came up with the first time I had to teach a course. Actually, the first time I taught this method, it was 9 principles. Now it's 4. And the first one is it's about exnovation. So again, the idea that rather than innovation, which is often seen as something that is brought externally and kind of brought externally and implemented locally to improve practices, for example, we recognize that the complexity of how healthcare happens requires people who work in this context to actually be very creative, adaptable, resourceful, and we need to kind of draw on that resource to think about how we improve practices in the future. So this idea of exnovation is about foregrounding the accomplishment and complexity of everyday practices. We collaborate. Reflexivity, again, I think I mentioned this, is about disrupting kind of habitual ways of thinking about practices, disrupt habitual ways of doing things by talking to one another through the sense-making process. And then care. Okay, so I've got a couple of slides here. I think everybody who comes to this will get a copy of, is that right? So, feel free to have a look. I won't say too much more about this, and I might leave it on this slide here so you can have a look at how these principles kind of support decision making when you're actually doing this work in practice. All right, thank you.
Thank you so much, Suyin. That was fantastic, so interesting and inspiring, and what a powerful tool for practice change. I really want to think about ways I can utilize it now, so thank you so much. And just a little reminder to everyone who's giving you lots of claps on the screen, which is lovely.
Oh yeah,
and if you have any questions for Suyin, we've got the chat box, which you can pop them in, and we're going to have a question and answer session afterwards. And similarly for Sam, when he's speaking, feel free to pop your questions into the chat box. But we will move on to Sam's presentation now, and I feel so fortunate to be able to introduce him. Sam works in the school that I'm based in, the School of Public Health at UQ, and he is a senior principal social scientist at the NHMRC Centre of Research Excellence on Achieving the Tobacco Endgame. But Sam is a fantastic researcher and does really interesting and beautiful research looking to integrate critical social science and public health research methods. He's aims to improve healthcare for marginalised populations through understanding complex experiences of health and illness that intersect with issues of culture, ethics and politics. He's always a pleasure to listen to when he is explaining his research, and particularly his research that he did in his recently completed PhD, which I think you're going to be sharing with us today, Sam. So take it away.
Thanks very much, Catherine. I'm just trying to share my slides and having difficulty.
Karen, I wonder if you can
Karen,
get
am I still
Sam's
a
slides
presenter?
to appear.
Yes, I'll jump in, Sam, if you like, and share.
Yeah. Oh dear, well, that's not coming up.
There we go.
Thanks very much, Karen. So I'll just tell you when we go to the next slide. Is that right?
Yes, that's right.
Yeah, cool. All right. The perfect system. Okay, yes, so good afternoon, everyone. Yeah, my name's Sam. Thanks for attending this session on ethnographic research practices. And thanks for the introduction, Catherine. Yeah, so I guess the term, I probably call myself a clinician researcher. So half the time I'm a clinical nurse working in the emergency department and also in some humanitarian contexts overseas. And in the other half, I'm a qualitative health researcher here at the UQ School of Public Health. And so my research has focused primarily on drug use and addiction. And my PhD research was an ethnographic project looking at the process of recovery from harmful methamphetamine use. So that's what I'll be talking about mostly today, and focusing on some of the methodological and also the ethical challenges that arise in the process of doing this kind of ethnography, particularly those challenges that come up for clinicians doing this research, who can sometimes be sort of caught between different ethical frameworks. Next slide, please. And so yeah, ethnography has always been the kind of research I'm interested in doing. I happen to be the kind of researcher that's most interested in those research methods that present the least likelihood of me having to open up an Excel spreadsheet. And so one based fundamentally on going out into the world and talking to people, often in an intentionally unstructured way, seem to fulfill that very important criteria. But to justify in a more methodologically legitimate way, I was also very inspired by the long and rich history of using ethnography to explore drug use. This is going back to Alfred Lindsmith in 1938, Michael Agar in 1973. One of the more significant ones more recently is Philippe Bourgois in 2003. These are studies that have painted a rich, detailed picture of how drug use happens in the real world. It creates these three-dimensional understandings of people. It humanizes people that can otherwise be dehumanized, either because of addiction or other causes of marginalization. And so then those understandings can then support ideas like harm reduction and treatment services and really drive policy action. And so a lot of it is tied up in the title of that first essay there by Linda Smith, the sociological theory of drug addiction, as opposed to, say, a psychological theory. So I would say ethnography as a method, it's suggesting that in addition to turning the world into numbers and into data, we can also understand it sociologically as this large interconnected process that can be understood more as a whole rather than only being broken down into constituent parts. And that's particularly useful for these other complex social processes. Just click again for me, Karen. I think like inequality more generally, poverty and eviction, things like incarceration, release back to society that are explored by these other excellent authors here that I would strongly recommend if you want to see applications of ethnography to issues sort of outside of health, but obviously deeply interconnected with health. Ethnography is one of those things that can show through that three-dimensional picture how health is interconnected with all of its social determinants and commercial determinants and things like that. All right, next slide, please, Karen. And so there's obviously many different forms of ethnography. As Cian was talking about, a lot that are using different forms of technology. My experience is with, I guess, what you might call a more classic form of ethnography. It's a sort of a quote unquote simple, deceptively simple approach based on naturalistic observation, ethnographic interviewing, taking field notes, analyzing transcripts. It's about following people around in their daily lives. I refer to this as sociological stalking a lot. Basically, I call it stalking people with their permission. Stalking people who know you're doing it and have signed a consent form. And what it is you do in the process of that following can be different for different research goals, for different ethnographers, different based on the relationship you have. Matthew Desmond, who's won the Pulitzer Prize for his ethnography, his claim is that ethnography is what you do and you try to understand people by allowing their lives to mold your own as fully and genuinely as possible. And different researchers would do that to different degrees, but I think the thing I would focus in though is about it being genuine. That's what I'll come back to a bit later on. It's about having genuine relationships with the participants in the ethnography. And then there's another quote from Lisa Ma, who was one of my thesis supervisors. She's making the comment that devoid of field-derived contextual knowledge, so what we get out of an ethnography, epidemiology can homogenize vulnerability. So we can gain data on all these different issues, and it's very important that we do that. There's a lot more detail and a lot more context that can get blanked out if we don't supplement it or combine it with something like ethnography. And so this is sometimes called putting flesh on the bones of epidemiological analysis. Next slide, please, Karen. And this is another quote that I refer to sort of describe the process of ethnography. Forgive me if everyone's already very familiar with this, but I was told it's a diverse audience. So, it's another way of describing what ethnography is, where, as these guys say, as a set of methods, ethnography is not far removed from the means that we all use in everyday life to make sense of our surroundings, of other people's actions, and perhaps even of what we do ourselves. What is distinctive is that it involves a more deliberate and systematic approach than is common for most of us most of the time, one in which data are specifically sought to illuminate research questions, are carefully recorded, and where the process of analysis draws on previous studies and involves intense reflection, including the critical assessment of competing interpretations. So I think in some ways this kind of ethnography, it's simple, but it's not easy. All right, next slide, please, Carol. And so just a brief overview of what my study was. I had 12 participants. They were recruited through an outpatient drug and alcohol service. So people accessing recovery services for whom methamphetamine was the primary drug of concern. We did ethnographic observation over a 6-month period, primarily focused on recovery-related events. So the observation was going with people to see doctors, see counselors, parole officers, going into rehab, coming out of rehab, but also seeing family, friends, moving house, drug dealers, basically trying to see as much of their lives as I could. This was combined with semi-structured qualitative interviews. So each participant had 3 interviews across the 6 months, the beginning, middle, and the end. And then we conducted thematic analysis on the interview transcripts and the field notes. And if you just click again for me, Karen, this is an example of just some of the papers that were derived from the study. And I looked at various different aspects of the data, and then ultimately we came up with a model called extended recovery, which I don't have time to go into any of that here. If you would like any copies of any of these, please do get in touch. Okay, next slide, please. So I thought I'd talk through, before getting into the ethical stuff, some of the methodological issues with just combining observation and interviews. This is by no means a methodological innovation on my part, but this was an aspect of the method that I thought I could talk about. Some people obviously will just be qualitative interviews, some people will only do observation. I tried to combine unstructured observation with semi-structured interviews. Some of the benefits of this were, I found you could use the interviews to reflect on the periods of observation. So being able to shift between these different roles, observer and interviewer, could be useful. I might observe people in social situations, in clinical situations. You don't necessarily want to interpose questions or impose yourself on the scene more than is necessary. You want it to play out as much as possible as if you're not there. But then the interview provided an opportunity to reflect on that situation with the participant. Also, being able to do the in-depth qualitative interview and then contextualize what was said there with the data from the rest of their real life was very useful. So you can talk to the participant about their life, then also talk to a family member, a friend, a clinician they know well. So you're doing a kind of triangulation on what has happened to them and what their experience has been. And obviously doing the serial interviews and doing observations over that period of time gives you the opportunity to observe transitions and changes between the different interview points. Next slide, please, Karen. Some of the challenges of doing both of these, sort of the inverse of some of the benefits. There's the risk of the participants sort of treating each interaction like it was an interview. People may be familiar, if you're doing an hour-long qualitative interview with people, it's not therapeutic, but it can have a therapeutic vibe to it sometimes. I think especially people who are used to accessing services, used to seeing counselors, psychologists, and doctors, they're used to slipping into that mode with someone who's sitting there asking them questions. And so I found I had to make an effort to not always be in that role with them, because you also want to, as much as possible, be someone who's just a member of their social world rather than someone there in a professional capacity. It can become challenging to navigate the bounds of the relationship between that sort of quasi-therapeutic setting, times when you are supportive of them, times when you want to be neutral towards them, and I'll talk about that a bit more in the ethical challenges. You have issues with consent. There's multiple different consent processes going on. You have one more formal consent process for the participants, and then as other people enter a social scene, how and when do you gain consent from them? Defining where and when the field becomes difficult. A lot of ethnographies where you're sort of out in the field doing observation, they might pick a place. So you do an ethnography of a treatment center or of a clinic. Mine was of just 12 different people out living their lives in different parts of Brisbane. There's no sort of walking into the field and then walking out of the field again. You're taking phone calls, you're in touch with people, and also getting texts from people late at night. So there's sort of data hosing in from all directions. And then obviously the data analysis becomes challenging because it's very rich, but it's a very big data set. So you end up with, I think I had over 100,000 words of field notes and hours and hours of interview transcripts. So, which is a great opportunity, but then because you've left it so open and you've gained so many kinds of data from so many different directions, how you turn that into something that's legible and actually generates insight is another challenge. Next slide, please, Karen. And so then to touch on some of the ethical challenges, before I wrap up here, this is sort of derived from this. This is the latest study and hopefully the last to come out from my PhD thesis, which is just sort of reflecting on some of the ethical issues that came up as a nurse going into this environment. Some of the not necessarily conflicts, but tensions. If we go to the next slide. This is some of the quotes lead off this paper with, whereas this is the Australian National Health and Medical Research Council pointing out, research, like everyday life, often generates ethical dilemmas, which it may be impossible to find agreement on what is right or wrong. And I would say ethnographic fieldwork is particularly well poised to generate those kinds of dilemmas. And then this other one from Russell and Barley saying that ethnographers that deal with issues of social justice think very carefully about these issues. They're sometimes stuck managing tension between what is deemed ethically sound research practice and what is the morally right thing to do. And you can end up in that situation sometimes where your behavior you've ticked all the boxes, you've done everything you were supposed to do as per the ethics submission you put in however many months ago. You sort of know what you're safe from attack, but still what you did could have been harmful to people, or may have been harmful to the participants, or maybe wasn't as safe as it could have been for the participants even. Okay, next slide, please. So for the clinician ethnographer, some of the ethical challenges that I found where there's this difference between beneficent. I was focusing specifically on beneficence in this paper. So doing good, how do we do good? What is doing good for a patient versus doing good for the wider community? So in a clinical setting, your goal is to do good for the individual in front of you. In research, we can not actively do good for the person who is the participant because we have this broader goal of good coming from the research project. And so this came up in things like not providing assistance to participants that I might have been able to provide. This was For example, I would drive participants around a lot. Lots of them, pretty much none of them had a car. They all needed to get to a lot of places. It was an easy way to make my way into their life and gain sort of contact with them. Then one of the participants is going to buy drugs. They need to get across town to buy some methamphetamine. It becomes a question of whether or not I want to drive them over there to do that. And there's lots and lots of factors that were at play there, which we go through in the paper that I won't go into detail now. Basically, the answer of navigating through that was through talking it through with the participant, through not sort of secluding myself and coming to a decision based on an abstract theoretical framework, but basing it on my relationship with them and talking it through with them to try to find a way to not be stigmatizing towards them, to not endanger our relationship, but also do it in a way that sort of lined up with the different kinds of ethics I felt beholden to. Times when you kind of felt like you were failing a perceived duty of care. I mean, as a clinician, you don't automatically have a duty of care towards anyone, but once one has been established, then you're meant to maintain it. And you could say that as a researcher, I don't have any duty of care towards any of these participants in that way. But then, as some people may know, when you've done like an hour-long qualitative interview, you're visiting people in their home, you're making plans to see them again soon, you're intentionally developing a relationship with them, it can feel like a duty of care has been established. And so then later when they get upset about something, or they're needing, they're needing to be consoled about something, or they're needing help out of a situation they're in, it becomes a question of when and how do I resist my instinct to sort of kick into gear and become that sort of case manager role for them, which is a kind of ethnography you could do and could justify, but wasn't the one I was trying to do. And then the other thing is the way you can accidentally influence people's trajectories, and this is speaking to the impossibility of neutral observation. You can't be you're a physical person in the room. There's no way your position there is neutral. I had one participant who went to access a treatment service. I went there with them, and then talking to one of the clinicians there later on, they told me that because I was there with them, I was taken to be somehow vouching for them, and that influenced their decision in a great way to admit them to the treatment service, which was very misplaced because they discharged themselves just a couple of days later. And so that was and this is all the things that go through in this paper as a reflection point for me, where it's not necessarily that anything was done wrong there, but it's about thinking ahead more explicitly about those sort of issues as they may come up, and making sure that you and the participant are making informed decisions about what it is you're doing. Next slide, please, Karen. And so in the concepts of relational ethics and the microethical environment I won't go into now, that's sort of the theoretical basis I've drawn in the paper to arrive at this conclusion. But basically the conclusion I arrive at is that navigating ethical situations in ethnographic fieldwork is best guided by a genuine relationship with the participant based on authenticity and solidarity. And I mean, that's also the best guide in a lot of clinical situations as well. You're developing treatment recommendations or care plans. It works best when it's done in direct collaboration with the patient, based on an understanding that there isn't any superiority or authority inherent within the clinician as a person. As individuals, you are the same. And next slide, please. And this is sort of where we lead off in that paper. So I would say that these research situations, they're not sufficiently navigated by a binary injunction to either do good for the participant or do good for the community. Each of these actions are carried out in the context of a mutual trust and respect between myself and the participants, where I was trying to engage honestly and openly with their experiences and not ignore the ways we were both dependent on the other for our various goals. And so by engaging in these kinds of relational ethical processes, I negotiated my best guess at ethical actions at each moment, while also trying to reflexively examine my missteps and blunders once I've left the field. And this can sometimes be the best case scenario when a PhD student confidently sets out to do good. All right, next slide. And I think that's all I've got time for. Thank you all very much for your attention. I want to acknowledge all the participants in the research I was talking about, and my advisory team and the services that are involved. And yeah, feel free to get in touch if you want copies of any of these papers or ask more questions. I am available. Thank you very much.
Thank you, Sam, and Yin as well. A belated thank you from me, but that was wonderful. I think that we had some really interesting questions in the discussion, and also moving off of Sam's points around the ethics of your relationship with participants. And I think Catherine has just a quick little anecdote to share about some ethnography she did, covert ethnography with ethics approval.
Thanks, Victoria. Thank you, Sam. That was fantastic. Although I was reflecting on my most recent ethnographic experience, where my research is all around sort of the commercial determinants of health and following powerful elites and what they are doing, the tactics and the strategies they are doing. And so I had ethics approval to attend a corporate affairs conference and do participant observation in terms of what these senior executives were saying around, their concerns and fears and their tactics for engaging with the public and policymakers. And we had approval for waived consent and limited disclosure from our ethics committee. And so there was no relationship development that was happening. It was just a very standoffish observation approach. But just as a cautionary tale for those of you who are interested in that sort of method, we had significant problems getting it published in a health journal. Health journals, even though we had ethics approval, they clearly were very uncomfortable with that approach. And so we've had to get it published in a communications journal. So just a little the other side of the spectrum of participant observation and ethnography.
Yeah, I think you raise a really interesting point, and I like how you framed that particular issue as working with sort of powerful and elites. And in Sam's situation, there was certainly an element of vulnerability. And then again, with Yin's talk, that sort of facilitator role and the participants engaging, it's again a different sort of almost, I don't want to say democratic, but it's more of that co-research relationship that you've got with your participants. So very different dynamics of power going on, and how the concept of consent and participation really plays out quite differently. Catherine, do you want to lead the questions?
Yeah, sure. We had a great one from Lisa, who was saying to Yin that she loved the approach that you outlined, but was wondering how do you get people to agree to participate? And there was a follow-on from that as well, which was what happens if someone changes their mind on the day they've been of recordings when they have been told about it previously?
Yeah, it's interesting because when I first saw that question, thanks Lisa for asking it. I had a straightforward answer, and then I listened to Sam's presentation and I was like, oh no, hang on, it's more than that. And then after hearing Catherine's one as well. So I think the short answer is I spend a lot of time first with them so that they know who I am. And that's more about being admitted to being allowed to work in a place like a ward or a facility, right? So they know who I am and I explain what I do. And part of the explanation is that it's always done not just with their like written consent, but it's like a moment to moment, are you comfortable with this? And once they know who I am and see how I work, we trial it, and I'm always asking, so what do you think? Shall we keep this footage? Do you think we should show it? That kind of thing. So it's always moment to moment. It's always contingent on their comfort and enthusiasm. So there is the sense that it's not just they grudgingly let me do it as well. If they're slightly uncomfortable, it's actually really important that I'm very conservative about that, because it's very easy for them to be silently uncomfortable, right? And in doing so, I damage not only the trust, but also the idea of what informed consent is. So it's very relational, similar to Sam's. Yeah. And I think...
You go, Sia.
Yeah. Oh, no, I just noticed that Haylock also had a question that was related to that. So like what happens if somebody changes their mind on the day?
Yeah.
Actually, I was reflecting on what Sam was just talking about as well with that, because I've done that. I've turned up when I've organized the entire team, the junior doctors, the senior doctors, the medical students, everybody, that can I come with you on your round and video it? when I rock up, and of course there's somebody new who's in a relatively junior position, and the whole team wants to do it, and this junior, this junior burgers on the side going, oh no, what's going on, So there are things I can do in that situation because I desperately need this project to go ahead. But if I cannot do it, like I can say, you stand next to me so we don't video you, or I'll make sure not to video you, or that kind of thing. But if I cannot do it, I will not do it. It's that's more important. As painful as it is.
Thank you. And Sam, what about you recruiting? I mean, I think that would be an incredibly tricky group to recruit. How did you go about it?
Yeah, well, I had a couple of these outpatient drug and alcohol services, and basically got the nurses there that were seeing patients to identify potential participants for me, and then they had a script to describe the project to potential participants, and basically got initial consent to give their contact details to me. And then I would contact them to try to finalize the consent process. But I think, I think the consent process, again, is another good example of, I think what I was referring to, the ways in which you can tick the boxes in terms of an ethical framework while still what's happening maybe isn't great, because like these guys, their lives are very chaotic. A lot of them are in and out of active addiction. And so the fact that I got them to scribble a signature on a piece of paper 6 months ago doesn't really translate into a meaningful consent, months later. So my counter to that was constantly sort of restating that process and sort of regaining that verbal consent from people and sort of reorientating them to the project. But I didn't really have to do that as per the ethics thing that got approved back at the beginning. Yeah, it's great to hear about your research with people in more powerful positions, because I think I was probably a bit too general in saying that this is what is the best ethical process in ethnographic fieldwork. Obviously, there's many different kinds, but in those situations where you are in a more powerful position than the participants. But I think, we need a lot more research of people in positions of power, because I think people in lower positions of power, lots of research ends up being about them because they have the hardest time fending us off because they're the least powerful people. So, it's not that it's not like the people in power, there's nothing to research about them. But I think when a PhD student is desperate to find a group of people that will let them do an ethnography on them, the people most likely are, unfortunately, the people who are the most systemically disadvantaged. That's why all the research is about them.
Thanks, Sam. I think we've got time for one more question, and then Victoria might do a wrap up or even pose final questions. So Tim, you've put forward a question on ideas of ethnography of active. Are you ethnography around stigma? Is that what you're saying, Tim?
Yeah, around active stigmatizers.
Sam or Siyin, do you have any thought, or even Victoria, do you have any thoughts on this? What are active stigmatizers? I'm going to have to show my ignorance here.
Yeah.
Sure. Specifically, case in point at the moment, those who stigmatise against the LGBTIQA+ community. More broadly, it might be stigmatising against weight or age or ethnic background. So it's easy enough to recruit those who are on the good side of, or in the middle or unaware, but those who are actively stigmatising, they're just not going to see anything beyond, hi, we're looking to speak to people about this. Don't want to know. And so the idea of, Catherine, what you're saying about the covert operation, that's been crossing my mind, but yeah.
But I just say too, so using social media is a technique that I know a lot of people use to gain insight into those groups. And you can, I mean, that's where the whole, like what this waived, it's the consent issue. That's a big discussion that's going on in the ethnography world at the moment. And so that's an area that you might want to consider. I don't know if Sam or Siyin or Victoria have any additional thoughts.
It's a tricky thing, I think, because with something like ethnography, traditionally one of the first stages in it, you have to decide what your subject is and who it is that you're looking at. And in terms of people who are perpetrating stigma or enacting stigma, there's people who will join a group for that. You have people at the real pointy end and people who are real extreme in their views, and that's a perfectly valid subject for analysis. So you can go and try and do an ethnography on that group. But then there's that much broader swathe of ways in which that stigma is enacted in people's everyday lives. And so that's a hard thing to gain traction on, because it's, sort of where are you looking for it? Like, the enacting of that stigma isn't something this person does as a specific activity that you can go and observe. It's sort of how they interpret the world. So yeah, that's why I think, like, social media, not necessarily doing it directly with people, but social media posts or just media is a way of doing that. But yeah, I'm not sure what the answer is there. The classic ethnographic answer is you find a group of people who are organized around their shared belief in, the inferiority of a particular group, and there's value to that. But again, there's a tip of an iceberg, and how you see the rest of the iceberg. Yeah, I don't have an easy answer for it.
Thanks.
Thanks. I'm just aware we've done 2 more questions have snuck in. Victoria, do you think we should address those, or are we going to wrap up? There's
I'm
a question
wondering whether
around
we should maybe we could follow those up sort of over email or something.
Yeah,
'Cause
I
we
mean, there
only
is a
have 2
very
more
quick one.
minutes.
There's a quick one
Yeah.
here for Sam. Do you talk in your consent form, did you mention that or do you think going forward it would be good to state that you can't assist participants beyond the scope of the project?
Yeah. Well, you try and say that in the project. I try to say very explicitly, you will gain nothing from this, even though in practice they often do. But yeah, you try and avoid that expectation.
Okay, thank you. And I am really happy to talk to Asnake about the retail store. We can get in touch if you like. Victoria, do you want to wrap it up?
Yeah, I really think I could keep having this conversation for another hour. So I'm finding it very hard to wrap up, except that I just really appreciated both all the discussion, in fact, around sort of the value of ethnography and the humanizing capability that it has, the richness, and just that real attention to relationships and that thoughtful way of interacting with people that carries through to the research that you produce, but also as you are carrying it out at the time. And so, yeah, it's just lovely to have a chance to hear about that in detail. And I thank everyone, and we'll follow up the session probably with some publication resources and things. I do wonder about whether it would be nice to have some sort of a Teams channel or something to, this is a community of practice, and so a way to continue conversations that don't just have to happen within a 1-hour time slot. So maybe I'll just have a little brainstorm about that with Catherine, and we will keep you posted. But thanks everyone. Have a great afternoon.